Well, thanks, Dan. And I guess maybe my first comment about David Yorston is that he was when I came to Kikuyu in 1997 after leaving the U.S. Army, they expected a little bit more of me, and they were gracious enough to let me learn surgery from them for the first year or two that it took me to get up to speed. But David could never get over the idea that I was actually really a CIA agent. Maybe he still thinks that. The approach that I'm going to take to this talk is a little bit of the thinking that we were going through, me and my partner, Dan Mundia, in how to best do service delivery for pediatric cataract patients in our setting. And worldwide, an estimated 1.4 million children are blind, and about 200,000 of those are due to bilateral cataract, due to complications of surgery or due to amblyopia related to pediatric cataracts. The vast majority of those are in Africa and Asia, and those are more often, almost always in poverty areas. The prevalence of cataracts in children is difficult to calculate. It's somewhere between 1 and 15 per 10,000 people. It's probably higher in developing countries. And Alan Foster, the president of CBM, has estimated that about 4 children per million have cataract in industrialized countries and about 10 children per million in developing countries. And I think in Kenya, we felt that it was probably even a little bit higher than that due to poverty, and also because we saw a lot of patients who would come across the border from Somalia, where there was essentially no healthcare system. There's a number of unique challenges to doing pediatric cataract surgery in a mission setting or in any developing world setting. Equipment was always a challenge, and here our staff is really excited about having this vitrector from the Dort company. It turned out to be a real clunker, but we were really excited to have it. It's difficult to get things like portable keratometers and so on, and then it's difficult to retain top-performing staff. We had a couple of very excellent surgeons who were very, very good at pediatric cataracts, and then they decided to go into private practice, and they no longer did surgery on children anymore. As alluded to earlier, parents often can't afford the fees, and follow-up is difficult because most parents have the mindset of, we're going to go to the hospital, we're going to get this problem fixed, we'll come home and everything will be fine. And it's hard for them to have the idea that they're actually going to require multiple visits. So my experience is limited to the country of Kenya, specifically Nairobi and areas around Nairobi. Kenya currently has a population of about 40 million people. Almost half the population is below the age of 15, lots of children. Around the capital of Nairobi, there was about 3 million people, roughly, and about 20% of people were below the poverty line in the country, according to UNICEF. I was aware of 6 facilities in Kenya that offered pediatric cataract surgery. There may have been a few more cases done in some of the government hospitals, but as I understood it, none of them had vitrectors and none of them were fully equipped to do pediatric cataract surgery. And speaking with my colleagues, there was roughly 600 to 800 cases done per year in the country. And interestingly, 3 of those centers doing pediatric cataract surgery were in the capital city. The other 3 were all mission facilities that were in various parts of rural Kenya. I was working at Kikuyu Hospital, which there's actually a chapter devoted to Kikuyu Hospital in the international section of the basic and clinical science series put out by the American Academy. It's a 100-year-old hospital that was started by Scottish Presbyterians, and the eye unit was started by an Australian doctor about 30 years ago. And CBM was the primary donor for all of those years. When David Yorston was there, they began using IOLs in everybody, the IOLs from India. And around 1995, they started putting them in children as well, which was really at the forefront of efforts to improve the quality of pediatric cataract surgery. And they had a wonderful opportunity to have a very large patient population to do their studies on. We had an A-scan available from the beginning, and around 2003, my friend Keith Robleski from the Army graciously donated us a portable keratometer, and so we were able to do good biometry since then. we eventually got some good vitrectors, and we had 2 Accurus vitrectors for about the last 5 years, one of them donated by Standard Chartered Bank. So David Yorston published his series of pediatric cataracts in 2001, and it was one of the largest series at that time of IOL surgery in children. And he had very good, very respectable results, with about almost 50% of children were seeing 20/60 or better. 90% were 2200 or better. And mind you, these are children that have been delayed. They have delayed presentation. Sometimes they would have amblyopia, and in fact, the most frequent cause of poor vision was amblyopia. It was challenging to find that fibrin was present in about a third of the patients, and that's a constant problem in pediatric cataract surgery, even here in the States. So there were a number of challenges. Last year, me and my partner, Dan Mundia, looked at our results over the last 3 years, and we looked at almost 100 children, and the results as part of a study of comparing simultaneous same-day surgery on both eyes and sequential surgery on different days. And our results were about the same as David Yorston's, maybe slightly better. We had maybe about 70% of eyes that were 6/18 or better. And we still had a lot of fibrin. Up to about a third of patients had some degree of fibrin. Fortunately, it was usually small amounts. And again, the most frequent cause of poor vision was amblyopia, and many times that was due to delay in presentation. So we wanted to really try to maximize our donor dollars, because we had to do virtually all of our patients at no charge, because the parents simply couldn't afford paying for surgery, because virtually every cataract patient that was a child also came from a poor family. So we were fortunate enough to have donations from a local bank called Standard Chartered Bank, but we wanted to stretch those dollars as far as we could, so we started looking for ways to be more efficient and to save money. And we thought, well, what if we just do both eyes at the same time? Is there any precedence for that in the literature? And I went back and I looked, and I found an article from 1990 by Dr. Guo, and he had 16 patients, did same-day surgery in both eyes, but with no IOLs. He reported really good results. But in the same year, another group from, I believe from Philadelphia, reported 3 cases of endophthalmitis in pediatric cataract surgery. So that really put a damper on the idea of bilateral simultaneous surgery. David Wilson from Portland also pooled the results of various pediatric ophthalmologists around the country, and he came up with an incidence of endophthalmitis of about 0.7%. And their recommendation was not to do both eyes at the same time. So at least in the North American literature, there was a strong caution against doing both eyes at the same time. Elsewhere around the world, about 10 years later, Toten in Turkey looked at 41 patients that he did same-day surgery on, and of those, 5 of them were children between the age of 10 and 19, and he reported good results. I guess I'll just continue. And since that time, in the last few years, there's been a few more reports of bilateral simultaneous cataract surgery, in some of them in children. Still going? Okay. So in 2009, this was a study from a French group. They reported 40 patients that were done, young children, infants, that were done bilaterally on the same day. And none of them had IOLs. They were all treated with contact lenses, but they reported good results with no complications, and they also reported that it was attractive to do both eyes at the same time. The following year, Toten from Turkey reported a larger group of his pediatric patients that had been done simultaneously, 20 of whom had IOLs, and he also had good results and no complications. And then this past year, Nalasamy and then Scott Lambert at Emory have also reported simultaneous surgery on both eyes. Scott Lambert's study report just came out last year, was comparing same-day surgery on infants less than the age of 6 months, and about half the group was bilateral same-day surgery and the other half was sequential surgery. And he reported a savings in the bilateral cases of approximately 20%, and recommended it for young infants. So we decided to do a retrospective study because we just sort of quietly started doing both eyes at the same time for various reasons, one of which was to save money, and we have to admit that's why we did it. We wanted to try to save money. And so we looked at the results of 3 years, all of our patients with bilateral cataracts under the age of 10 years, because we felt like children above the age of 10 years were a lot more like adults than children. We wanted to have symmetric IOL placement, either the bag or the sulcus, and we wanted at least one post-op refraction between the 2 weeks and 3 months post-operatively. We were comparing those who were operated on the same day, both eyes, versus those that were sequential. We looked at the total cost for all the supplies and the ward stay and everything. And I was curious to see whether there was any benefit to waiting to do the second eye to see whether if you refracted the first eye, if you could get a better predictability of the outcome of the second eye. I was quite curious because normally Dr. Mundia and I would take turns on a patient. I would operate one eye on Monday. He would operate the second eye on Thursday. And we had a very, very good refractionist who could manage to refract most of the children the morning, about 3 days post-op, the morning before they would go in to do the second eye. And so based on that initial refraction, I would try to adjust the IOL power up or down to see if I could get closer to the desired refraction. And when I looked at the results of that, it turned out that 1 month, about 2 months later, the 2-month refraction was within a diopter of that 3-day refraction in about 80% of children. So I felt that that was a reasonably accurate refraction. And then we also wanted to look at the early and late complications. In our setup, we had a setup patterned after Aravind where we're doing high-volume surgery. We are using separate drapes and instruments for each eye, but we were using the same irrigation bottle and the same infusion set for 5, 6 cases before we would change it. All of the children had A-scan and keratometry, and it was a lens aspiration procedure with an intraocular lens either in the bag. We would put it in the bag if we had an intact capsulorhexis. We would put it in the sulcus if we did not. And all patients had a pars plana anterior vitrectomy with an Accurus vitrector. So we managed to enroll 96 patients in our retrospective study. That was about half of the patients we had done, but there were a number of others who didn't attend follow-up, didn't have a refraction, had one eye with the IOL in the bag, the other eye with the IOL in the sulcus. So about half our patients met the inclusion criteria. The simultaneous group was actually significantly younger, and that was because we did have a tendency to operate young infants, both eyes on the same day, because it was a little bit traumatic putting them under anesthesia 2 times in a row. And we calculated the surgery costs, the total for everything, the supplies and everything, we calculated it to be about 20% less, about $274 for the simultaneous group. That was not really factoring in the cost of somebody like me because I was free to the hospital courtesy of CBM. But one of the things that surprised me was that the prediction error was not better on the second eye in sequential cases. I expected that the prediction error would be less on the second eye when in fact it was actually worse. So doing that refraction on the 3rd or 4th day post-op and trying to adjust the IOL power turned out to not be beneficial and actually, at least in our series, made it worse. The prediction error in the simultaneous cases was roughly the same in between the right and left eye, and it was not statistically significant. Early complications, again, about 1/3 of eyes would have some degree of fibrin. Fortunately, it was very small, and it would usually resolve within a few days in both eyes. A few patients had fibrin in both eyes. A few had early synechia, but there was no difference between the 2 groups. And then in late complications, there was no real statistically significant difference. There was a little bit more irregular pupils and synechia in the simultaneous cases, but that was also a younger group of patients. Everything else was pretty much the same. So we wanted to know, what kind of risk are we taking by doing both eyes at the same time? Are we putting a child at risk? Are we risking a case of bilateral blindness from doing this in children? And in the literature, I'm aware of four reported cases of bilateral endophthalmitis from simultaneous surgery. A couple of those were in the 70s in Africa with intracapsular techniques, but with modern techniques, there's really only one or two cases. And I know Steve Arshinoff in Canada has advocated strongly for bilateral simultaneous surgery in adults. But we went back and we looked at a larger database of ours, a larger group of patients of about 800 IOL cases over an 11-year period, and we were able to identify 3 known cases of early endophthalmitis. There was probably more than that. There were probably a few patients who were discharged from the hospital and never returned. But even if it was double or triple that, it's still a pretty low rate of early endophthalmitis. And since we started using intracameral antibiotics in 2007, I think our number is even lower than that. We also reviewed a record of about 3,600 pediatric cases of all types, and we're aware of about 4 anesthetic deaths out of those. So at least on the surface of things, it appeared that our rate of endophthalmitis in children was not too much different than the risk of death from anesthesia. So that was a little bit reassuring to us that we weren't putting the child at a greater risk by operating both eyes at the same time. So there were numerous advantages to operating on both eyes. There was the efficiency and the cost savings, roughly 20%. The parents loved it. They were much more enthusiastic about having both eyes done at the same time. We would usually keep the child on the ward for about 3 or 4 days post-op because we couldn't trust the parents to put the drops in. And so we would always have our ward staff put the drops in or teach the mother while they were there for a few days. And so simultaneous surgery meant a 5-day ward stay instead of an 8, 9, 10-day ward stay. And there was also a reduced chance of deprivational amblyopia because there were cases where we would do one eye and then the child would get sick and he wouldn't get back to the theater for a month or sometimes never. They would never come back. The disadvantages was the risk of possible endophthalmitis. The child would be more uncomfortable having both eyes operated, but really I couldn't think of any other real significant risks. So to conclude my talk, there's a number of challenges doing pediatric cataract surgery in a developing world setting. It's something that I fell into. I thank God for having that opportunity. It's something that God gives us, that opportunity. He opens doors sometimes that we don't expect. I trained as a general ophthalmologist. I saw my residency director doing pediatric cataract surgery, and not the director, but the pediatric person, and I just thought, that is just so cool, but I'll never do that. And then God opened the door for me to do that and gave me a chance to do it for many years. So, and now the Lord gives, the Lord takes away. He's taken me out of that situation. It's a little bit painful. It kind of breaks my heart to not be doing it right now. But that's God's decision to do those things. But I want to acknowledge my wife and my children for putting up with all of my passion about doing eye surgery in a developing world setting. My wife, Sally, has a much greater reward in heaven than I do for all the things she's put up with, including colleagues like David Yorston. And so I just want to thank you for the opportunity to speak.